My topic is going to be the Belin ABCD Progression Display, History, and Utilization. I often get a question, why do we need a progression display? After all, we have the Belin ambrosia or the bad display. Can't we just follow the final D? We have the ABCD staging or grading system. Can't we just follow that? The answer really is no. Each of these has a distinct utilization. Now, the bad display was designed specifically to separate normal from abnormal. It's useful, but it's not specific for ectatic disease. It's really risk screening or risk analysis for refractive surgery. Now, it can be used as one inclusion criteria in keratoconus studies, but the final D shows deviation from normal, but not necessarily progression of the disease. Now, what do we mean by that? Well, let's look at these three examples. The upper right display is hyperopic LASIK, clearly not ectatic disease. The lower left is post-refractive surgery, again, an abnormal cornea, but again, not specific for ectatic disease. And the lower right is endothelial dysfunction or corneal edema. If you have a markedly thickened cornea, it is an abnormal cornea. It will give you an abnormal final D, but again, not specific for ectatic disease. Well, this was recognized, the need for a new system was recognized years before, but was published as a consensus document in 2015 in the journal Cornea. This was the work of the four major multinational cornea societies. And what did they conclude? Well, they stated, in order to diagnose keratoconus, you had to have abnormal posterior elevation, abnormal corneal thickness distribution. Notice the absence of anterior changes here. They also stated that the best current and widely available diagnostic test to diagnose early disease is tomography, be that either Scheimpflug or OCT. And they went further and stated that posterior corneal elevation abnormalities must be present to diagnose early or subclinical disease. Well, what do they conclude about classifications or staging? Well, they acknowledged that the often used, and unfortunately often still used, but vastly outdated classification systems, either Amsler-Krumeich or incl. And they recognized that tomography as a critical diagnostic component, but they also agreed that a suitable classification system utilizing this new information, in other words, tomographically based, did not currently exist. And that was really the motivation behind our work on the ABCD. We all know the limitations of Amsler-Krumeich, and it pains me every time I see someone refer to it. One, it relies on apical thickness, and actually it was based on optical pachymetry. It completely ignores the posterior corneal surface. You can see here on the bad display a highly abnormal cornea, but one that has a normal anterior surface. This, what we call subclinical, but this is pretty advanced subclinical disease, is completely ignored by Amsler-Krumeich and also actually by incl. Also, if you really look at it, it's somewhat of a useless classification. Let's look at this example here. This is a 35-year-old with a pachymetry of 485, a mean K of 54, and an RX of -3, -150, axis 88. Well, what stage is this? Well, the pachymetry puts it at stage 2, the K readings at stage 3, and the RX at stage 1. So when someone tells me this patient is stage 2, I have no idea what this really means. Let's look at these examples. Here we have two patients, an 18-year-old with a PAC of 410, a mean K of 52, and an RX of -8. And then we have a 47-year-old with a PAC of 544, a mean K of 48.5, and an RX of -525. I think no one in the audience would think these two patients are alike, and you treat them very differently. But in Amsler-Krumeich, they're actually both graded exactly the same. They're stage 2, a pretty meaningless classification. So the ABCD was really developed because of the lack of a tomographically based system that was recognized in that consensus document. The ABCD looks at each anatomical layer individually. A stands for anterior, and it's the anterior radius of curvature. taken from a 3 mm zone centered on the thinnest point, not an apical reading. B stands for back. It's the posterior radius of curvature, again, from a 3 mm zone centered on the thinnest point. C is minimal corneal thickness, again, not an apical reading. And D is user-entered best spectacle corrected distance visual acuity. In addition, we added an additional stage called stage 0. If you think about it, with Amsler-Krumeich, everyone in the world is at least stage 1, which makes no sense. So stage 0 doesn't really mean completely normal, but it's a much earlier stage. And again, most patients who are normal will fall into that stage. But you can have some very early cones who would also fall into stage 0. The ABCD classification or staging is currently available on the topometric Keratoconus staging display, and it gives you actually 3 different ways of showing you the information. The least useful is what most people think about when they think about the ABCD, and that is the actual bottom classification. Staging or classifications are usually done for population-based studies. You group patients into certain categories. So here we can say A0, normal anterior surface, B4, prominent posterior ectasia, C3, a moderately advanced thinning, but normal visual acuity, D0, because the anterior surface is normal. The graphical display will actually give you more information because it really shows you exactly where in the spectrum they fall. But the most useful information that's patient-specific are the numbers here, which actually gives you actual readings on the anterior, posterior, and corneal thickness, as well as distance visual acuity. So again, the next question is, well, can't we just follow the parameters from the ABCD as opposed to having a separate progression display? And again, as I said, staging tends to be better for population-based studies. Let's look at this example here. I think this is actually basal metabolic rate, or BMI. If we look at this, let's say the patient in green, if they went from 18.5 all the way up to 24.8, a very big change, they're still in that same category. But if you had another person who was 24.9 and went to 25, they would jump into a whole new stage. So again, good for population studies, but not really a way to follow individual patients. In addition, I'm just going to throw out, we actually will be making a slight adjustment to the C parameter on the next software update. The actual C parameter is going to be updated somewhat based on some work we did in larger databases. So we go back. Why a progression display? And we're going to go back again to that consensus document. And here's what they stated about how to define ectasia progression. They stated there's no consistent or clear definition of ectasia progression. And they defined progression as a consistent change in at least 2 of the following parameters, and this is the important part, where the magnitude of the change is above the normal noise of the testing system. And those are either steepening of the anterior corneal surface, steepening of the posterior corneal surface, or thinning and or increase in the rate of corneal thickness change from the periphery to the thinnest point, in other words, pachymetric progression. But if we look at historically all the progression parameters people have published on, and if we look down this entire list, other than pachymetry here, every single one of these is anterior corneal based. So again, it's missing all changes on the posterior surface. In addition, we have a reliance in the past on Kmax. And Kmax, I think we all acknowledge now, is really a very poor parameter. It's a poor efficacy parameter, and it's a terrible progression parameter because it really means that you've waited too long. In order to have changes in Kmax, you already have to have changes on that anterior surface of the cornea, which means you've lost vision. And again, that would be like looking at a patient with glaucoma and saying, well, the pressure's 25. We're not treating you until it gets worse. And that's not how we treat disease. The goal should not be to treat after you've had damage. It should be to prevent the sequelae of disease. And that you can't do if you rely on the anterior corneal surface. So we need to know when and if true progression occurs. And I go back to that statement from the consensus document. It has to have, the change has to be above the noise of the system. and we need to know it as early as possible. So the ABCD progression display was designed specifically to follow and document progression of disease. It's based on one-sided confidence intervals because we're only interested if the cornea steepens or if the cornea thins. It allows for documenting progression in spite of a stable anterior surface or a stable Kmax, and we'll show you examples of these, and it evaluates each anatomical layer individually. And as we said, in order to do that, we needed to determine the background noise of these parameters. Now, the A and B parameters are new parameters, so we did not have confidence intervals or noise levels for these. So we ended up having to do an initial study. We did this a number of years ago. And right off the bat, we knew that we had to look at both normals and abnormals. In other words, keratoconic patients. And the reason for that is we know in almost every test that the more abnormal the cornea is, the more noisy the measurements are going to be. So for your older patients with clinically evident keratoconus, the noise levels from the keratoconic patient database are probably more appropriate for progression determination. In addition, the older patient is less likely to exhibit rapid change, so the risk of waiting is lower. But for the young patient or that with very early or what we call subclinical disease, their noise levels are probably closer approximate that of a normal population. In addition, we know younger patients with normal vision can actually have changes much more rapidly than the older. Here, the risk of waiting is much higher. So again, we show you the confidence intervals based on two different populations, both normal and keratoconic. And we did we did the study and did the one-sided confidence intervals. We determined the confidence intervals both at 80% and 95%. And if you look at the numbers again, it's not important for you to remember the numbers. This is all done automatically by the machine, but you'll notice exactly what we anticipated, and that is the noise levels in red, which is the keratoconic population, are higher than the noise levels in green. And this is actually the second iteration for what the current display looks like. It displays graphically up to 8 exams over time and displays each anatomical layer individually. A, anterior surface, B, back posterior surface, C, minimal corneal thickness, and D, distance visual acuity, which is not machine generated but operator entered. You can also see here that the confidence intervals, the 80% confidence intervals are shown by the dotted line, the 95 by the solid, the normal population is in green, and the keratoconic in red. And as you will always see, again, the red flags are further to the right because they're noisier measurements. So you need greater change based on the keratoconic population. We also show a number of different parameters in tabular format. You can see here the ABCD classification, the bad D, the final D, progression index, ART max, Kmax, Q values, and a number of the anterior surface parameters that people have followed in the past. So these are not displayed graphically, but we do show those over time. Now, the display is actually simple, but there's a lot on the display that you probably will never use. And I kind of make a reference, it's like a car manual. There's a lot of features you probably will never use. It's nice to know they're there, and I'll spend just a little time going over them. First, the machine will default to the first exam as baseline, but you can pick any exam as baseline. Again, it defaults to the oldest or the first exam. If you do a treatment, and for this we usually mean cross-linking, you check off a box here when the treatment was done. You can choose to show only the normal population database or the keratoconic. It defaults to show both. And here is an example, the same patient. Here we checked off only showing the normal population, and here's the keratoconic population. Again, it defaults to show both. When you want to do this, particularly if you're dealing with a young patient or someone with early disease, that you're going to rely on the normal population confidence intervals. For medical legal reasons, I would probably only want to show those because I wouldn't want someone questioning, well, doctor, it hasn't reached the 95 in the red bar yet, because the red is really not applicable for the younger. But again, most of the time you're just going to leave it in default when it shows both. A rather confusing is that there's two ways to actually show the data. One is called aligned at baseline, and the other one is called full scale. It defaults to aligned at baseline. What is the difference between the two? Well, aligned at baseline is designed best for determining progression. If you look at the scales of each of these A, B, C, and D, notice the scales are all different. That's because each individual parameter is maximized to show the biggest separation between the confidence intervals. The other option is called full scale. Full scale, if you notice, the scales are identical throughout. But problem with full scale, while it maintains the anatomical relationship, notice how close some of these confidence intervals get. So because this is a progression display, it will default to aligned at baseline to give us the easiest way to visualize when progression actually occurs. Next is if you show when a treatment has been done, you'll notice that the confidence intervals will no longer appear. So the confidence intervals were determined in a normal population and a keratoconic, none of those having been operated on. So once you do a treatment, the confidence intervals are no longer applicable. We'll discuss that later. So let's look at a couple quick examples. This is a 15-year-old with advanced keratoconus, 7 years follow-up. You can go back and historically look at patients, and here you can see over time continued progressive disease. And if you look way down here at Kmax, wherever it is, you'll see that Kmax continues to increase also. But here are some examples that really show you the value of this display. This is a 15-year-old, very early keratoconus, 13 months follow-up. Look at the Kmax, 46.1, 45.5, 45.8, basically no change. Look at the anterior surface, effectively no change. But look what's going on in the back of the cornea. By the second exam, past the 80% confidence interval. By the third exam, way past the 95%. This, unfortunately, is a patient at most areas insurance won't cover it because they don't have changes in Kmax. They have progressive disease in a 15-year-old. This one needs to be treated. Here's a 16-year-old with progressive subclinical disease. Again, notice Kmax 48.9, 49.8, just under that one diopter that in at least many countries, I know in the U.S., we're required to show. But look what's going on. Changes on the anterior surface well past the 95, changes on the back surface well past the 95, and corneal thinning well past the 95% confidence interval. Each layer, A, B, and C, well past the 95% confidence interval, yet most insurance companies will not cover. Here's an 18-year-old, again, stable Kmax. Notice the Kmax, 48.6 goes to 48.4, 46, and actually gets better, 44.2. But again, look what's going on in the back of the cornea. Progressive disease, in spite of a stable, are actually improving Kmax. Now, it's not just early disease. This is an example of a patient with moderately advanced. The final bad D in this patient started off at 7. But absolutely stable Kmax. But again, look what's happening. By the third exam here, progressive change. By the fourth exam here, and this is the keratoconic population, past the 80%, and on corneal thinning, past the 95%. So one parameter past 80, another parameter past 95, in spite of the fact that we have a stable anterior surface. So how do we diagnose progression of keratoconus? Well, we recognize that there's a dissociation of clinical progression with changes in Kmax. We now have a tomographic-based classification system that recognizes all the anatomical layers, and a tomographic-based progression display that documents when we have statistically significant change. And also this can be used on older historical files, so you can actually go back and review past information with the new software. But this is a meeting about cross-linking, so I'm finally getting to it. Well, how do we define progression after cross-linking? Well, progression parameters after cross-linking had been previously unknown, and as I stated, once you show that the cross-linking treatment has been done, the confidence intervals are dropped out. So we did a study in conjunction with the Elser Institute here in Switzerland and the Hamburg Keratoconus Center in Germany. We looked at patients with a minimum of 12 months post-cross-linking. We took 3 separate Pentacam measurements, removing the patient between each exam. We required a minimum of 7.5 millimeters of coverage and an acceptable quality score. We did both pooled variance and one-sided confidence intervals were computed, and we also compared whether that was site-specific or time-specific. We looked at a combined 60 patients. There were 38 from Zurich and 22 from Hamburg. The ages were very similar, about just under 30, but the time since cross-linking were very different between the two populations or geographic areas. Zurich averaged 16.6 months with a range of 12 to 28, while Hamburg averaged 42.6 with a range of 16 months all the way out to 115 months after cross-linking. And we'll show how we interpret that later. These are the one-sided confidence intervals. They were generated the same way we did for the non-cross-linking patients. And again, these will be in the future incorporated into the display. But what we wanted to know, because it is different in a surgical patient, in other words, a normal patient or a keratoconic population, we can assume is fairly similar in different locations. But surgery is different, so we wanted to know, because not everyone does everything the same, we wanted to know if there was a geographic difference between Zurich and Hamburg. So that first chart you see here shows that the populations have similar ABC values. And while somewhat confusing, the graphical display below shows that the populations have similar noise measurements. So there did not appear to be a difference in geographic location between Zurich and Hamburg. We also looked the same way for geographic comparison between standard deviations, coefficient of variation. And while I am not a statistician, effectively what we did here is we proved the null hypothesis so that there was not a difference between the two. And again, we looked both at standard deviation and coefficient of variation. The Hamburg population, while it was only 22 patients, allowed us to also look at the time since cross-linking, since there was a very wide range in their population, between 16 months and 115 months. We divided that population into two groups. The first 11, which was from 16 months to 35 months, and the second 11, which was from 38 months to 115 months. And you can see graphically here that there's effectively no difference in the noise levels between the, quote, short term and the long term. So this suggests that once you get out to about 12 months post cross-linking, the noise measurements are consistent throughout. This is another way to look at the same thing, but actually, this was actually done throughout both populations. And I'm not a statistician, but I can tell you what this basically tells you again, is that the correlation between time post-cross-linking and noise shows that there is not a variation once you get out past 12 months. So again, this supports the noise measurements are consistent after 12 months. So what did all this tell us? Well, it told us that the post-cross-linking measurement variance or noise can be used to determine progressive change. Noise measurements were consistent across different centers, here Zurich and Hamburg. Noise measurements were consistent once you got out 12 months past cross-linking. And the new confidence intervals will be added to the next iteration of the Belin ABCD Progression Display. And the reason for that is, while not very common, we do know that there are some patients who've had cross-linking who may need additional treatment and may have progressive disease, and we need a way to follow those patients. And this is an example or a mock-up of what the next iteration that will incorporate this will look like. There will be an additional confidence interval shown here in blue. They will only appear after a treatment has been indicated and only appear 12 months after the treatment. So again, you have here the green population, which is normal, the red, keratoconic, preoperatively, and then here you will see, most likely in blue, confidence intervals of the post-cross-linking, but again will only appear from the 12-month post-cross-linking exam and after. So I hope this information has been useful. I want to acknowledge my co-investigators and thank you virtually.